Well, good morning and welcome to CyberSight. I see we have a lot of participants. That's good to see. My name is Sheraz Daya. I'm the medical director at Center for Sight, and my specialty is cornea and the anterior segment and refractive surgery. I'm going to be speaking to you today about keratoconus. Now, for many of you in the audience, I expect you know all this, a good portion of it, but I'm almost certain you'll learn something new. Anyway. It's a very long talk because I'm going to be covering a lot of material. I'll be going very, very quickly. So just to start, I like to start with fundamentals whenever I give a talk. I'm going to talk about the cornea. So the cornea, you need to understand what the anatomy of the cornea is. It consists of the epithelium, which you can see very clearly at the top here, about 6 layers. It remodels, can go up to 12 layers or more. There's Bowman's layer, which is a layer right behind the epithelium, and then the bulk of the cornea is the stroma, and then you've got Descemet's membrane and the endothelium. Now, if you notice, the cornea architecture is a lot more compact anteriorly, coalescing to Bowman's layer, and a lot less compact posteriorly. The collagen is arranged in such a fashion that the corneal tissue is transparent. So this is the anterior stromal structure here. You can see it's a crisscross lamellar pattern. And as you go more posteriorly, it becomes more loosely arranged, still clear, but it's that loose arrangement is of significance in conditions like keratoconus. Now, the textbooks will say that keratoconus is a progressive, non-inflammatory thinning disorder of the cornea, leading to altered shape and adversely affecting visual performance. The reality is it is actually inflammatory. It is not non-inflammatory. Just because the eye is not red doesn't mean there's no low-grade inflammation taking place. So there's a variety of ectasia that results from the cornea thinning out. Keratoconus is the most common. It can occur centrally or inferiorly. Then there's pellucid marginal degeneration, which is another thinning ectatic disorder, and that occurs at the margin, towards the margin of the cornea in the far periphery. And keratoglobus involves the whole cornea. What are the facts about keratoconus? Well, it varies a lot in terms of prevalence. In countries like the Middle East, and the number of cases is about 1 in 200, and it increases to about 1,800 in some parts of the world. There's a strong association with atopy, people rubbing their eyes. And Damon Gatnell, a good friend and expert in this area, has got a great video on YouTube showing what happens to the eye when patients rub their eyes. So patients must not rub their eyes. Why do they rub their eyes? Well, the eyes get inflamed. And remember I said to you about inflammation being a contributing factor, not just from eye rubbing, but actually the cytokines influences the elasticity of the cornea. So there's definite rationale for reducing inflammation when you see it, and treating chirurgic conjunctivitis quite aggressively with mast cell stabilizers and steroids, and even cyclosporin topically if necessary. It is an asymmetric condition. The onset is usually during puberty, and the hallmarks are progressive myopia. So optometrists will see these patients first, and then they eventually develop irregular astigmatism, corneal thinning and cone deformation. And as I said, the association is with atopy, eye rubbing, Down syndrome, and Marfan syndrome as well. So what is the pathogenesis? Why does this all begin? Now, a lot of people are homing in on just one area, the genetics. That doesn't make any sense because there are other things that take place. Genetics might identify areas of collagen abnormalities. However, there are other issues. As I said, there are inflammatory cytokines that may be present. So in this table, courtesy of Jesus Merayo from Oviedo in Spain, he's divided it up into atopy, contact lens related, hormonal, systemic conditions, and then there are mechanisms here. Now, you don't have to remember all this stuff. Just suffice it to say it's a multifactorial condition, a lot of causes there. But as everything in life, the common things are common: eye rubbing, allergies. And with any degeneration, it's an imbalance. Typically, the body regenerates itself. Otherwise, we wouldn't be standing still. We'd just be crumbling. So as we degenerate, as things get degraded, we have healing mechanisms that regenerates us. When that balance gets upset and there's more degradation than there's regeneration, then you get disease. And that's essentially what happens with the cornea. So we're not getting a rehealing of the corneal stroma, and it thins out, and it gets worse because you've got aggravating factors that contribute to degradation. So how does one make the diagnosis? Clinically is a big one, especially in developing countries. There's topography that can be used. Corneal hysteresis is a bit more sophisticated. It looks at the elasticity of the cornea and its ability to be deformed. And then there's epithelial mapping as well. So let's go through each one of these. Clinical is vital. We're all doctors. We want to be able to examine patients, and we have to use the slit lamp to the best that we can. Patients will come in because they've got problems with their vision. And why is that? Their myopia is increasing and their astigmatism is increasing. So optometrists need to be warned. If you see this happening, think keratoconus, especially if you see them rubbing their eyes in the waiting room or otherwise. Retinoscopy is very, very useful. I find that amazing when it comes to looking at patients' corneas. And you'll see, I mean, in an extreme case of keratoconus, you get this droplet type appearance. But you might actually see scissoring. So when you see scissoring, you know that astigmatism is a bit irregular, it's going in the wrong direction. At the very extreme, you'll see Munson sign. This is a patient with high drops, bad keratoconus, and Munson sign is where the lid, because the cone is so ectatic, the lid is being pushed away from the globe. That's Munson sign. There's Rizzuti sign, which is where you shine a light in the periphery of the cornea, where this pointer is, and you see an angle of light at the other side. And that's a sort of an optical phenomenon from the keratoconus and the ectasia. But there are more common signs that you need to look for. Of course, keratoconus causes central thinning, so you look for that. And because there's stresses on Bowman's layer and lacquer cracks, you can find there's apical scarring, because those little cracks have to heal. And you can see that in this image over here. There's an apical scarring. Sometimes the scarring can be caused by contact lenses that are on the eye too. And then when you get stress factors in the posterior cornea, and you see what's called Boxtree. They're vertical lines. If you indent the cornea with a Q-tip or your finger right by the lid, you can make those striae disappear. So those are stress lines on Descemet's membrane. So you can understand when the keratoconus gets extreme, those stress lines can result in a tear in Descemet's membrane, and you get what's called hydrops. A Fleischer-Ring is an iron line, and it's an iron line because it's deposition of tears at the base of the keratoconus. And I'll show you all these signs in a moment. So here we go. So this is the Fleischer-Ring. I don't know if you can see it on your screens there, but there's a Fleischer-Ring at the top here. This keratoconus is so extreme, there's no Fleischer-Ring. It's actually out in the periphery if it's present at all. Now we're using cobalt blue. Why do we use cobalt blue? Because iron, which is brown, absorbs the light. Actually, it's probably better with using a green filter, because green light will be absorbed by the iron line. And that's another Fleischer-Ring right there with the arrows. So this is Boxtree. I don't know if you can see them. They're very, very fine lines right in the center there. And as I say, if you push on the corneal limbus, you can make those go away. This is the extreme. When the cornea is stretched so far, you wind up getting a tear in Descemet's membrane, and then you get swelling in the cornea. Now, we know from doing surgery, we can tear Descemet's membrane and they don't get any swelling. So what's the difference? Why is it that keratoconus patients who have a tear in Descemet's membrane get a swelling? Well, the reason for that is they actually get a Descemet's membrane detachment, as you can see here on this OCT. So the Descemet's membrane is separated away from the cornea. It tears and it separates. Because it separates, you get corneal swelling. Now, the traditional way of taking care of this has been give the patient cycloplegics, steroids, and wait until it goes away. It winds up often with a scar in the center or in the area. Hopefully, it doesn't involve the visual axis. And sometimes the cornea gets flatter and patients see better. But they're in pain for quite a long time and they can't see. If they've got a Descemet's detachment, well, it's very simple. We do demarcs and desects. You could inject air into the anterior chamber under pressure and push Descemet's membrane back up again. You just have to be careful the pressure doesn't go up too high, but that actually does work and reduces the healing time by about 4 or 5 months. This is pellucid marginal degeneration. You can see the thinning of the cornea in the periphery. So the central cornea is fine, but the peripheral cornea is very, very thin. As pellucid meaning clear, marginal towards the periphery, degeneration. This is keratoglobus. This is a patient of mine from Israel who could have this condition, was diagnosed as keratoconus when he was a small child at the age of 4 or 5, and been seeing over the years. And you can see his cornea there is paper thin from limbus to limbus. And not only is it thin, he's got megalocornea. His corneal diameter was 17.5 millimeters. Normal is about 11 to 12.5. So this is 17 millimeter cornea. And in this case, I did a lamellograph, which was quite challenging. And I still see him now, 15 years later, and he's doing very, very well. So those are the clinical signs, and that's what you need to be looking for. But how can you diagnose keratoconus perhaps earlier? Well, they have a steep cornea, and the steepening is inferior. So if you have corneal topography or even a placido ring, you can see these are the rings here. This is the astigmatism is oval shaped, and the rings are closer together in the inferior portion of the cornea compared to the superior portion. This tells us that rate of change inferiority is much higher. They've got inferior steepening. Now with topography, you can see this quite clearly. This is a sagittal keratometry map of the cornea that shows inferior steepening. And what we're looking for in corneal tomography, where you're looking at the anterior elevation, posterior elevation, corneal pachymetry here. This is anterior elevation here, posterior elevation. All these three coincide. And that also is a good hallmark of keratoconus. And then there are grades of keratoconus. There's a mild keratoconus. Could it be subclinical? They've got inferior steepening. The bow tie is not symmetric. So this could be the start of keratoconus. It goes on to mild keratoconus, which looks a bit like this. So that area of steepening should be in the center, is inferior, and that increases with time, and then it becomes severe. So these are different grading systems. There's the ABCD scale from Berlin, which I think is a good one, and one that you can consider. I'm not really one for grading systems. They're very useful for research, and I like the terms subclinical, mild, moderate, severe. Anyway, that's me. So what sort of three-dimensional topography systems do we have? The ORB Scan was one of the earliest, dating back from 1995, 1996. It's now going by the wayside. It's scanning slit beams across the cornea. Scheimpflug cameras are extremely useful. There are many of them out there right now. There are some that have become the gold standard. Then now we're moving to OCT-based corneal tomography with devices like the Cassia 2, the MS39, the Anterior from Heidelberg, who are great supporters of Orbis, and also Optical, and there are more coming. So this is the ORB Scan. The video on this doesn't work, but it scans with slit beams right across, takes the images and takes the video images and maps out where the slits are, and figures out mathematically what the anterior and posterior elevation is, and there's a placido to measure the power map. This is Scheimpflug imaging on the pentacam, and you can see the cornea here. It goes in a circle around the cornea, so it actually gives you a lot more central information. And it's 2 integrated cameras, 50 Scheimpflug images in 1 second, in one scan, which takes less than 2 seconds. And this is sort of topography that we're looking at, the quad map that the ORB Scan came up with. The great thing about this sort of device is you can take a look and you can see how change takes place. So this is a patient who had keratoconus. This is pre-collagen crosslinking, which I'll talk about in a moment. And this is post-op. And you can see the difference. It looks quite similar if you look at it qualitatively. But if you look at the numbers, then you can see there's a difference. But the systems can do this for us by subtracting one from the other, and you can see that this cornea has flattened centrally with that blue area. There's ultrasound digital topography, which is also useful in looking at this, but it also looks at epithelial thickness mapping, which we know is important nowadays for diagnosing keratoconus early, where the epithelium is really good at remodeling the cornea, and it gets thicker in the periphery and thin at the apex. So epithelial thickness mapping is extremely useful. We use it all the time now for screening patients with refractive surgery, because we don't want to do anybody who's got early keratoconus, or any keratoconus for that matter. Corneal biomechanics. This is ultimately, you want to know how elastic the cornea is. And what better way to do it than to actually prod on it, push on it, and we do that with air. And how the cornea recovers tells us quite a bit. And so what we're looking at is hysteresis. This is the applanation pressure. This is the amount of deformation and how the cornea recovers. And the difference is hysteresis. If the hysteresis is too low, it's very elastic. Now, this has all been visually imaged on the corvus from Oculus, and you can see the image above is keratoconus versus a normal. When you look at that keratoconus, you'll see it wobbles and deforms a lot more. So it oscillates, and that's an elastic cornea. This is courtesy of Renato Ambrosio from Brazil, who did a lot of work on this in this area. So again, going back to the diagnosis of keratoconus, so you've got all these gadgets, but clinical is really, really important. If you have oblique or against the rule astigmatism, which has been increasing, scissoring on retinoscopy, those are very, very useful pointers for keratoconus. And if you want to actually measure it, well, 3D tomography probably is a gold standard, and hysteresis is useful, but you don't all have to have biomechanical measures of corneas to make the diagnosis of keratoconus. So what are the treatment options for keratoconus? Well, traditionally, it has been spectacles, followed by contact lenses. They start off with soft lenses, then they go to toric, and then they find they can't see with those, and they go to gas permeable lenses. Then eventually they graduate to scleral lenses for those that can fit them. Now, those are not available. It's a specialty fit. And then when they can't tolerate lenses anymore, they wind up having a corneal transplant. That's what used to happen. It used to be a full thickness graft, a penetrating keratoplasty. We gradually moved to lamellar keratoplasties. But a lot has happened in the intervening years. And what has happened? Well, things have changed now. One of the biggest changes to the management of keratoconus has been the advent of collagen crosslinking. We've been doing this since 2004, and it really has changed the course for a lot of patients with keratoconus. The important thing is to diagnose people early and stop them progressing, and collagen crosslinking can do that. It can sometimes be combined with PRK. I don't often do that, but it can regularize the cornea as well. There are people who will do this, and they'll try and play in extreme cases. It doesn't work in extreme cases. Mild cases, fine. Intracorneal rings have come along. There's Intacs, Ferrara rings, Kerra rings, the Maya ring, and now Kerra Natural, which I'll be talking about, or CARES, corneal allograft, so from rings made from corneal tissue, intrastromal corneal rings. There's toric phakic lenses can be used in patients who have good spectacle correction and don't want to wear spectacles. And then there's finally this corneal transplantation. So let's talk about keratoconus a little bit. About crosslinking. Crosslinking uses a riboflavin, a large molecule. It unfortunately doesn't penetrate the epithelial tight junction, so you're going to have a way of breaking down the epithelium. And there are some measures to remove those tight junctions using, say, tetracaine and certain riboflavin solutions. A lot of work has been done on epithelial removal, which is the Dresden method, but not necessarily the protocol, which is 30 minutes of 3 milliwatts of ultraviolet light. But you need to get that epithelium off, or you need to disrupt it. We've been using a disruptive method, and that's worked quite well, but it takes quite a long time for riboflavin to penetrate. When the riboflavin penetrates the cornea, and we check to make sure it's in the cornea, it all looks yellow, then we can go ahead and collagen crosslink. So how does it work? It's really, as we get older, ever wonder why people get wrinkles as they get older? Well, actually, that's collagen crosslinking taking place. It's an aging process where the collagen becomes a lot more rigid, and it becomes more rigid because it's cross-linked within the actual lamellar fibers. It can occur in people with chronic hypoglycemia, hypoglycemia from diabetes mellitus, for instance. Their tissue gets cross-linked, and it's been used in the past to strengthen collagenous valves, say for cardiac surgery, where they do valve replacements. And now we have it for the cornea, where we cross-link the cornea to make it stronger. So essentially, it's riboflavin penetration of the cornea, ultraviolet exposure, there's formation of free radicals, and there's an oxidation reaction, which develops cross-links within the collagen. Now, this is what all the images look like. So you've got more cross-linking that takes place as a result of the light exposure with riboflavin. Actually, it's probably within the collagen molecule itself, as opposed to adjacent molecules. They're too far, they're adjacent bits of collagen because they're too far away from each other. But suffice it to say, you get a lot more collagen rigidity. And this is a bit of cornea, a big cornea that's been treated with cross-linking, and this is one that is not as a control. This is the epithelial disruptive method. There's a little device that we use to break up the epithelium and to make a lot of pock marks in it. We use this in children because they can't really tolerate having the epithelium off. It's really painful. Their pain receptors are far more sensitive than adults, and it's kind of a mean thing to be doing. I think collagen cross-linking is probably the most uncomfortable thing we do in our as a procedure. So that's what it looks like. It looks like a medieval garrote or multiple garrotes. And we use that on the cornea to break up the epithelium, and then we put riboflavin on. And once the riboflavin is penetrated, it usually takes about 45 minutes. We check penetration of the slit lamp. We also give some powder carping to shrink the pupil, to make the pupil smaller, and make sure there's less light going through. If it does go through, usually it's absorbed by all the riboflavin. And then we go ahead and use ultraviolet light on the cornea. And we used to use 3 milliwatts for 30 minutes. Now it's 9 milliwatts for 10 minutes. And there are rapid cross-linking methods that have been developed. There's a great device that's been developed by Ferrara Ring called Imagine, where you can do cross-linking at the slit lamp. We have the device, and it'll have a transepithelial protocol. It's a bit more sophisticated than the traditional cross-linking devices. I don't think it's a huge rocket science. It's not that precise, but there are ways to enhance cross-linking, and they've done a really good job with that particular device. I have no financial interest in any of these things. We looked at our results in these patients. Pain is a big problem. 61% of our patients got a demarcation line, which I'll show you in a moment. And we always worry about ultraviolet light going through to the retina, and this illustrates that the amount of light that gets transmitted in a thick cornea, which is impregnated with riboflavin, is very, very low. This is a demarcation line. I don't know if you can see this video on your screens, but you see there's a line that's quite deep in this particular case, probably about 300 to 400 microns. And that's reassuring when we see that in the first month. And that tells us that something happened in that cornea in terms of cross-linking. And you can see that here with this OCT, there's a demarcation line there. And that's probably because something's happened with that collagen, and it's not transmitting light as clearly. It eventually will, and maybe it's a disruption of the relationship between glycosaminoglycans, the extracellular matrix, and collagen fibers. And when you get a disruption, you get a reduction in clarity. In other words, a bit of translucency and opacification. So that's collagen cross-linking, very good, and it's actually changed the course of keratoconus to the point where keratoconus is no longer the number one reason for doing a transplant. Now, the number one reason in the UK for transplant is Fuchs endothelial dystrophy. So these are intracorneal rings. This is in text in the video here that you're seeing. And how do they work? How do these plastic rings work? Well, what they do is they shorten the arc length. So in doing so, they flatten the central cornea. By putting rings in, raising up the periphery, it's an elastic dome, you wind up flattening the center. And the closer you are to the center, the more flattening you're going to get. So the Kerr rings and Ferrara rings at 5 millimeters will have far more effect because they're much more central. There are two ways to put rings in. One is conventional with a device where you can make a tunnel with a device. You use a diamond blade to go down to, say, 400 microns, and then you use this a ring on what looks a bit like a tree fine. You insert that and you dial it. Hopefully, you won't go through, but you dial it and you create a channel. Much more elegant ways to use a femtosecond laser. It's quick and it's a lot more precise, and you can also change channel diameters to suit. There are different rings will do different effects, and they have different nomograms for different types of cones. This is a Ferrara ring, which is very clever. It's shaped like a prism, so light comes in and it comes right out again. That's the goal of this was to reduce the edge effect of the rings. Now, it reduces it quite considerably, but it doesn't get rid of it completely. But patients are very good at tolerating this thing, so they might get like halos or edge effects to begin with, but over time, the brain shuts it down from neuroadaptation. So you can see the actual shadowing where light has not been transmitted in this particular cornea here. This is the Ferrara Ring in place. So the light comes in and goes straight out again. What are the indications? Well, if there's spectacle or contact lens intolerance, if the keratometry is up to 62 diopters, 62 and above is getting to be a bit extreme and it's less likely to work. They must have a clear visual axis. They can't have a scar. If there's a scar and you put a ring in, the vector forces will change the dynamics there, and you could wind up having a really irregular cornea afterwards. And the pachymetry ideally should be 400 microns in the center. So this is a video of Intacs going in with a femtosecond laser. So there's a laser docking onto the eye and creating the tunnel. This is in real time on a slow laser. It's a 30 kilohertz laser, and that's the incision there. And once that's accomplished, well, we need to make sure that before the bubbles go away, we're marking out where the channel should be. And so we can move the rings in those directions. This is a little hook that goes in to identify the posterior level. And it's like a pocketing hook. And once we've identified that, then we go ahead and we insert the Intacs ring. And this is quite a tight channel. I like tight channels. And it can be kind of tough to get those rings in. So we're putting the superior ring in first. Now, one of the things that does happen is when you put one ring in, the cornea deforms a little bit, and putting in the second ring can be a little bit challenging at times. And now here we are putting the second ring in. Keep the area moist with antibiotic. These are solid PMMA rings, and they have a habit of causing trouble at times. They can extrude, sometimes they can intrude, they can go into the anterior chamber. I've seen that. We used to put a suture in. I don't do that anymore because it becomes a focus for infection. Here we put a contact lens on, and we take that contact lens out within a couple of days. They use a lot of antibiotics afterwards. And these are OCTs, and these are images of Intacs in the eye. It's sort of hexagonal cross-section. So what are the complications that can occur from Intacs and Ferrara rings? They can get infections, usually often at the site or where they might extrude. They can extrude, as I mentioned. They can perforate into the eye, certainly during the procedure. You can get channel deposits, and sometimes they don't work. So this is a ring in place with a bit of an infiltrate here. This is a proper infiltrate at the site of the incision. These rings have kept the incision open, and they could have done with being pushed in a little bit more. And this is an extrusion. The patient complained of foreign body sensation seen by the optician who didn't know what was going on. And they came to see us, and sure enough, there's the Intacs was extruding, the cornea had melted above, and that Intacs had to be removed. These are channel deposits. These occur more often with mechanical creation of channels as opposed to femtosecond laser channels. These rings are slightly decentered, and you can see that these deposits are present. They do no harm, except if they were to increase to the point where they start going into the visual axis, you might want to consider removing them before that happens. Overall, the rings are extremely good. They improve contact lens tolerance, and they improve best spectral corrected visual acuity. There's a reduction in spherical equivalent mean Ks and astigmatism, and we have found from comparing mechanical insertion versus femtosecond that femtosecond is better. This is the new thing, and this is something we've been doing a lot of. I did a case today, a patient with 10 diopters of astigmatism with central keratoconus, and right after surgery, we checked her, she's only got 3 diopters left, and already her vision went from 6/120 to 6/18 straight after surgery. Very, very effective. And what's the difference? It is actually corneal tissue that we use, and we are very grateful to Eileen Killich and to Suzanne Jacob, who came up with this concept to use cornea. The cornea is kind of a selfish tissue. It only likes itself. You put plastic in there, it gets up to mischief. You put cornea in there, it integrates. And this is the Keranatural product is a pre-cut product from a Vision Gift. So you don't have to do anything. You can keep it on the shelf. Whenever you have a patient, you can use it. But it is corneal tissue, and it's acellular. It has been tested in terms of safety checks. So it's like a corneal graft, except it has no cells in it, and it is like a corneal graft safe to use. There are different nomograms used by different groups. This is just to show you a patient who has who's suitable for Keranatural. It's space filling and reinforcing. So this is a patient with Keratoconus. You can see the refraction here, minus 4.75, minus 6, giving an acuity of 612, which is not bad. And you can see that the area of deformation is here. This area here is quite extreme, and the coma in this patient will be on the other side. So what we want to do is fill in the space and move that cone into the center. And this is the treatment. This is the actual Keranatural graft. We've created a tunnel in the same way you saw with Intacs, but it's a much bigger tunnel. And this is kind of a ragged bit of tissue. The quality of tissue has improved dramatically in the last while. The one I did today was superb. But it doesn't really matter. It's tissue that needs to go into the right space. I'm just trying to identify which side is up, which is the anterior side. And here I'm lifting up the cornea and inserting it. And it's soft tissue. It's not like an Intacs, which is hard, which you can drive it forward. This takes a bit of doing, and ideally you'd have 2 incisions. So we now use a femtosecond laser that can create 2 incisions. You can actually create 2 incisions manually if you only have a laser like Intralaser creates 1 incision. And here I'm using a hook. You see it looks a bit clumsy, and this is it's been edited, I will admit, but just to illustrate this, all the videos you see sometimes are really, really smooth, but life is not like that. So here I want to get that ring all the way around to here. So it's a bit of pushing and shoving. As I say, I wish I had another incision to get it in place. So here we are, it's in place. I'm pushing it across. It's kind of concertinaed there, which is a bit of a problem. So what I need to do is overdo it, then put it back again. In this case, it looks like I left it that way. As I say, it didn't make any difference. The volume filling was accomplished, and this is what it looked like on this patient afterwards. You can see the coma, and this is what it looked like afterwards. This is pre-op, post-op. So quite a huge change in corneal topography. This is another patient that's got a ring in place. This is pre-op here in the middle, post-op on the left-hand side. And this is the difference map showing the amount of flattening of the cone, which I'm sure you'll agree is very impressive. This is a patient with a milder cone. And again, we put the ring in here, and you can see that there's flattening in the center. And this is what it looks like on high resolution OCT. You can see the Keranatural here. The cornea has been indented as well posteriorly, but the anterior surface is what we're really most concerned about. And that actually looks pretty good in terms of corneal shape. So that's rings, plastic rings, the Intacs, Kerra rings, Ferrara rings, and now cornea. And as far as I'm concerned, cornea probably is the way to go for the majority of these sorts of cases. What about corneal transplants? So we've gone through the gamut of treatments. What about transplants for keratoconus? Now, keratoconus, I got to say that when patients have grafts for keratoconus, in most cases, their endothelium is normal. So there's absolutely no reason to change the whole cornea. It's less safe surgery, and you put these poor patients at risk of rejection. So why doesn't everybody do anterior lamellar keratoplasties? Well, it is a little bit more difficult to perform this kind of surgery. So there's technical skill required. You could perforate. It's good to do some of the courses and to practice, but really you'll do your patients a phenomenal level of service if you do lamellar grafts. So let me see if I can convince you. This is penetrating keratoplasty. What are the hazards of doing a penetrating keratoplasty? You can get an expulsive hemorrhage. This is a patient who didn't have a graft for keratoconus. They had a graft for other things. This is the only eye. They were 16 years old. This is my patient. And they had an expulsive choroidal hemorrhage. So that was the only eye. That can happen. What is the incidence of choroidal hemorrhage in PK? would you believe is between 0.5 and 1%. So between 1 in 200 cases and 1 in 100 cases. So just be aware, penetrating keratoplasty is not without its troubles. You can get rejection and failure. So the mean survival for a corneal graft is between 17 and 20 years. But if somebody gets a graft in their, say, even 30 years old, by 50, they're going to have another one. Well, who wants to do that? And if they have to have a regraft, the chance of surviving a regraft goes down. And they can also get glaucoma. 19 to 30% of patients will get glaucoma. I hope I'm convincing you. Penetrating keratoplasty, if you can avoid it, is better. Do a lamellar graft if you can. Then they also get cataract and endophthalmitis because you got open sky situation. It's prone to risk. Now, this is a study that we did when I was director of the Queen Victoria, the corneoplastic unit at the Queen Victoria Hospital in East Grinstead. And we took a look at our outcomes of 3-year grafts versus the UK national outcomes. And our material was actually part of that UK transplant data. So it's a bit skewed in their favor. But you'll notice in keratoconus, the survival rate in the UK was 93% at 3 years. But what about the 7% that failed? In our case, only one patient had a rejection. That was a Down syndrome patient in a nursing home that was neglected, had an intumescent cataract, and that's why it failed, not from rejection. And the regraft rate, the regraft survival, so if you have to take a graft that's rejected and you have to regraft them, the national survival at 3 years is only 57%. Our survival was 67% better and statistically significant using cyclosporin and close vigilance and so on. But this doesn't have to happen. If you do a lamellar graft, the patient's tissue is their own. It'll never reject. They may reject their anterior cornea. It's easy to treat. So how can you do a deep anterior lamellar keratoplasty? That's a topic for another day. But just there are several techniques you can use. The big bubble technique of Anwar is a great one to master, but it cannot be done if you've got high drops or corneal scars that go down to Descemet's membrane. Viscodissection, advocated by Shigi Shimura from Japan, is another way of accomplishing the same thing. There's the pre-Descemet's method, which I use a lot because I get really extreme keratoconus, and it's the recognition of Melis. It's a good paper. I'll mention it in a moment. And then you can also use a femtosecond laser for those who use that habit. So this is a anterior lamellar keratoplasty using Melis's method, a modified Melis's method. Here I'm injecting air into the anterior chamber through a long paracentesis. A trephine is used to go to about 75% depth. And I'm pretty satisfied with that. And then I'll use a lamellar dissector to push away some of the stroma until I can see Descemet's membrane. But I'm also using that spatula to look for a black line. That black line is double the thickness of stroma between the instrument and Descemet's membrane. And we also find that when we go deep in the stroma, remember I said to you at the beginning of this lecture, posterior stroma is not less compact. Well, if you find it difficult to dissect, you're for sure you're too anterior in the cornea. If it's easy to dissect, as you can see me dissecting here, you are probably in the right place, quite deep in that cornea. So I'm just removing all that. I'm dissecting that cornea. And this is a video from about 20 years ago. So you see we've been doing this for a long time. Remove that anterior stroma. So we've got a little bit of lamellar tissue left behind, but that's okay. It's lamellar tissue with Descemet's membrane and endothelium, the patient's endothelium. We remove that. And actually, that's quite a good dissection. Very little stroma there. And I've removing the corneal tissue. And then we go ahead and suture in a graft where we've taken Descemet's membrane off. And here I'm using combined technique of 12 and 12, 12 interrupted sutures and 12 running. And not boring you with the suturing, this has been edited out, and you'll see it at the end here. The sutures are in. And the good thing with this is we can adjust for the astigmatism with a chamber formed, and using a Placido type ring, or even as the back of a safety pin, you can take a look to see what the mires are like to make sure that the astigmatism is corrected. So this is a much better technique, a lamellar graft, for patients who have keratoconus. And here we're just checking the mires to make sure they're circular. With a femtosecond laser, there's something that we developed with a laser where we have a configuration where it's like a tongue and groove. This is how tires for cars are treaded. They're treaded so that the treads go inward. So when you put pressure on them, they go in. If you were to go the other way, they would pop out. and you would detread tires. So the same principles are used in doing these kind of grafts. So this is using a femtosecond laser to create the donor. So here we're going through our pre-op flight checks, making sure the donor is correct and so on. We use an artificial anterior chamber using air to inflate the cornea to the right sort of pressure. Here I'm putting on the artificial chamber. This is a disposable device. You can use a non-disposable device, but because this is donor tissue, we worry about transmission through instrumentation. We will use disposable instruments where we can. So I'm locking in that graft. It has to have a good enough rim. Taking off the epithelium here after air has been injected. You see that cornea is pretty cloudy now. And then we go ahead and we use the laser. This is intralase to create the donor. And the donor in a geometric fashion using sort of the zag square technique. So here we go, and make sure that everything's fine. You'll see my view in a moment. This is what it looks like on the anterior chamber, and off we go with a cut. So what we're doing is we're cutting the cylinder going up from inside the eye up, and then across from the outside in, and then from the outside up to the anterior surface of the cornea. So this is all real time. So it takes a bit more time than maybe cutting a LASIK flap or making tunnels for rings, but we're getting a lot more cutting going on. And then we go ahead and cut the superior bit. And we make it taken care of, because now that cornea is penetrated, the graft can fly off if we're not careful. And this is what we do on the recipient. So this is going to be the big bubble technique, because there's no scarring. It's suitable for it. We put a ring on. And again, this is speeded up now. So the same thing that we did on the donor, we do on the host, except we don't go all the way through. We go down to about 400 to 450 microns in the periphery. So you can see that's a geometric cut. I'm going to make a long paracentesis in a moment. I'm pushing away Descemet's membrane here. Pushing away stroma so I can see Descemet's membrane. A long paracentesis. I say this is a speed up video. I don't operate this quickly. And this is a Fogler trocar from Rajesh Fogler from India. A very useful instrument, the Fogler cannula, to create that big bubble. You see the bubble there? And you see that the air inside the anterior chamber has become sausage shaped. It's gone off to one side. So we're removing this in 2 layers. I'm taking the top thick stroma off. The bubble is still in there. You can see the sausage shape on the periphery. And we do what's called a brave slash to cut the remaining stroma. And we inject viscoelastic, and you'll see that bubble move across. And now I'm going to remove that tissue. And you'll see that there's a nice shiny Descemet's membrane there that's left behind. The bubble is still in the eye. And this probably will provide patients with the best clarity when it comes to a deep anterior metacarpal. So the big bubble technique of Anwar is a superb technique for this sort of procedure. Here I'm removing Descemet's membrane, which sometimes is tedious. Put the graft on, marks, and off we go, and we suture the graft in place. And that's it with the 24-bite running in this particular situation. And this is what there's another patient, but this is what it looks like at 6 weeks. And you can see the configuration of the graft. It's this, you can see the true tongue here, the invagination, and the zag square on OCT. They heal very quickly, and usually about 9 months in a young person, we can take the sutures out. So that's grafting for keratoconus. And so I've gone through the gamut of the different procedures that we can use on different patients depending on how bad their keratoconus is. There was a Delphi panel of which I was a participant to look at global consensus on keratoconus and ectatic diseases and how to manage it. And there were three different groups. There was how do you diagnose keratoconus? And by the way, that's a very good paper to get from Cornea, the journal Cornea. There's one group that dealt with the diagnosis of keratoconus, another group dealt with non-surgical management, and then a third group dealt with surgical management, and that's the group that I was part of. That was quite a few years ago, probably about 8-9 years ago. And it resulted in publication, and this is the algorithm that they came up with. So just to illustrate it for you, so if you have keratoconus, you advise patients that from the diagnosis criteria that they've put together, you advise patients to stop rubbing their eyes, and you treat their allergies with whatever drops that are required. And I would say that, any patient with keratoconus, you really just treat them with anti-allergy drops. Any whiff of any inflammation, treat it. Consider cross-linking if they're young. And the consensus is if they're 21 or younger, don't wait for the keratoconus to get worse. It's going to get worse. Cross-link them anyway. If and it says cross-linking if suitable, and they're not suitable if their corneas are very, very thin. So it's something to consider. And then if their vision is good with glasses, they can stay with glasses, or they can consider contact lenses. If their vision is not good with glasses, then they need a trial of hard contact lenses or squirrel lenses. If it's satisfactory, you can leave them with those. If it's unsatisfactory or they can't tolerate contact lenses, then they move to surgery. And you can consider intracorneal rings. Nowadays it would be Keranatural. And then again, they go back into glasses or contact lenses. If rings are not satisfactory or they're not suitable, then unfortunately we have to move towards corneal transplantation, and a deep anterior lamellar keratoplasty is the preferred option, even if they've had previous eye drops. So I'm going to summarize that one more time my way. This is what I teach everybody. Keratoconus, I want to know, is it stable? If it is, keep them in glasses and contact lenses, and that's fine if they have good vision. You might want to consider toric phakic lenses like ICL in these patients, and that's between you and them. It's a very good option in those cases. If they can't, if they don't have good vision, contact lenses, hard lenses, or scleral lenses. You can now consider intracorneal rings to put them back into spectacles or even contact lenses. If they're progressive or less than 21 years of age, they have collagen crosslinking if they're suitable. And we do that on every patient that walks in through the door. And I often do bilateral crosslinking because what happens is they get one eye done, it's so painful they don't come back for the other eye. So I urge them to have both eyes done at the same time. And we watch them closely to make sure that they heal properly and so on. So if they are not suitable for crosslinking, and few are not, they will have contact lenses. And in time, they might have to have a lamellar keratoplasty. And now I'm happy to answer questions. There's quite a few on the Q&A. So let's start with the first one. What is your frank opinion of the no rub, no cone hypothesis of keratoconus etiology? I've already said that eye rubbing is a big problem. That should answer your question. They will get, if they rub their eyes, their keratoconus can start and increase. I'm not of the. I do believe that keratoconus can occur in elastic corneas without rubbing, but not as often. They usually are rubbing their eyes. Either way, keratoconus is keratoconus, and you need to tell patients if they've got it to stop rubbing their eyes. What is the final treatment options for advanced keratoconus? I hope I've answered that in my presentation. What do you think about the Athens protocol? Well, the Athens protocol, do we prefer Athens protocol? This is to do with PRK. As I mentioned, I have done PRK in some of these patients and very, very mild cases. What I actually do is I use PRK. I know what the epithelial thickness is in the center. I'll do enough PTK on the surface to eliminate a bit of the cone, and then use riboflavin. There's a lot of data out there. All the patients that come to see me after the so-called Athens protocol are ones that are got problems and require corneal transplants. And some of the cases I've seen have not been very good. Maybe they've been treated when they shouldn't have been treated. So that's up to yourselves. I like to look after patients, and I'll be careful with them. So I don't do any topographic linked PRK and cross-linking. I know some people do. It's been advocated even by the giants like Ferrara Ring. Again, I've taken care of a lot of keratoconus. I have done for 35 years. I don't do that because I think thinning out the cornea any more than you have to is not such a great idea. What is the earliest finding of keratoconus in clinical exam? I think I went through that already. Are all refractive procedures off limits for keratoconus? Well, corneal procedures, corneal refractive surgery is off limits. So I would avoid this at all costs. We've already talked about topographic linked topography to change corneal shape at the same time as cross-linking, or cross-link and then do PRK. For me, cross-linking is the most important thing in these patients. Get them stable. Sometimes when we do cross-link these patients, in fact, a lot of the time, the vision improves. Search me. topography doesn't change that much, but their vision improves. They might not need any topographic link, PRK, and so on. So give them a chance to cross-link first. So yes, all corneal procedures are probably off limits. However, if a patient sees well with spectacles, you could consider toric ICLs. They're a great option in these patients. The reliability of an OCT scan to detect keratoconus, I'm not sure what that means. I mean, if you've got topography and you've got epithelial thickness mapping from your OCT, that should really help you detect keratoconus. So I hope that sort of answers it. We're moving towards OCT mapping, and it depends what device you use, and they're all converging and doing the same sort of thing. How do you define keratoconus suspect and subclinical keratoconus? Well, basically, it's the same. We're talking about the same thing, really. If you see inferior steepening in the absence of contact lens and contact lens warpage, you need to worry about those patients. I think you can look at other parameters that we've already discussed in terms of epithelial thickness mapping. You can look at the progression of corneal thickness across the cornea. That's a whole other talk, and that's more related to selection of patients for laser eye surgery as opposed to keratoconus. But they do go together. You want to make sure you don't do anybody who might develop keratoconus in the future. So keratoconus suspect or subclinical keratoconus or form fruste keratoconus, another one to add to the mix, something to consider. For me, it's all much the same thing. If you have a patient with risk factors or early signs without having an advanced disease, do you recommend observation or can we look up to preventive treatment? It depends on age. And if you have somebody who's got progressive change, then they need cross-linking. Does that make sense? I mean, you're going to get patients who come to you because they've got a problem they can't see. And if their refraction is changing, their astigmatism is changing, and you pick up the retinoscope and they've got scissoring, and you believe they've got keratoconus, then cross-link them. You're doing them a favor. Observation is to me, is a nonsense, especially if they're young people. If they're in their 30s, 40s, and we don't know if they're progressing or not, then you could consider observing them, get some history. What was their refraction 2 years ago, 5 years ago, or even before that, and see what's changed in the meantime, and then consider it. Remember, this is you being a doctor approaching your patient clinically. You've got to treat that patient individually and customize treatment for that patient. How much time do you wait to do a procedure on a patient with eye drops? Well, usually with patients with eye drops, and the only procedure I would probably consider doing in them is going to be an lamellar graft. I usually wait 6 months before I do a lamellar graft in those patients, and I don't do a big bubble technique. I do a modified Mellis technique to get as deep as possible, and I keep the area where the eye drops occurred to the last before I take the cornea off. What image is the most sensitive for the diagnosis of keratoconus? Well, I don't think this is a competition. Okay, you can use placido imaging. You can use three-dimensional tomography, which is very sensitive because it looks at the posterior cornea. You can look at, let me bring this into the screen here. You can look at, I think posterior elevation mapping is very, very useful. And epithelial thickness mapping is also very useful. So you could, if you ask Dan Reinstein the question, he would tell you it's ultrasound using the ARC scan. If anybody wants to bother with it, you can diagnose keratoconus with any three-dimensional tomography. And the gold standard is probably a shine fluke at the moment, but OCT is taking over. But even a placido can help you and guide you. So I wouldn't wait. I wouldn't make this a big deal. I hope I've answered that question. In case of observation, how often do you recommend observation appointments with studies? Take your pick. I told you, if I like a look at history, I might probably do it in 6 months. If I just had no information and the patient was, say, 45 years old, and I just didn't believe that they were progressing, I would wait 6 months and then do a difference map using Pentacam or one of the OCT type methods. We have them all over here, 3 different OCTs and all sorts of mapping devices, and we'll use them and measure. What is the earliest age of keratoconus onset in children? It can be very young. We've treated patients as young as 5 years old, 6 years old. I now send them to somebody else because there are all sorts of issues with treating children. But we've cross-linked these kids, and I saw somebody I did when he was 7. He's now almost 20. He's at university and he's driving a car, and his corneas have not progressed, which is really, really good to see. He still has keratoconus, but it stayed the same. And yeah, that's very gratifying to see that, because he was heading to a corneal transplant. Can topography guided PRK followed by collagen cross-linking in the same setting be done for confirmed? I think I've already answered that question, so I'm not going to go over that again. How often do you see superior keratoconus? I don't think I've ever seen superior keratoconus. And maybe something else that's going on as opposed to superior keratoconus. The impact of intrastromal rings and cross-linking in patients with keratoconus. What's the question? The rates of corneal transplant reduces? Yes, it does. What we're trying to do is get patients rehabilitated so they can wear contact lenses or glasses. And if the rings fail, then we go ahead and they graduate to corneal transplants. So I already said that you're using these other methods, collagen cross-linking, intracorneal rings, our rate of transplantation has decreased dramatically, certainly in the UK. What about genetic testing for keratoconus? Yeah, I think this is useful. I'm not sure how much is going to guide me, though, because some of those genetic markers may be genetic markers for allergy too. There's a lot of work that needs to be done in this area, because it is not just genetics, as I mentioned in my opening slides. It's multifactorial. So it can help you, but then, the question is, what if it tells you it's there's moderate risk or there's evidence of risk? Is that going to influence anything? It might influence you as to whether you're going to do laser eye surgery, but this is a topic of keratoconus, not laser eye surgery. So I would leave. We're talking about diagnosing keratoconus and treating keratoconus, the actual condition. Is this important to treat this disease earlier? Yes. Please treat it as early as possible. So if you make a diagnosis of keratoconus, please cross-link that patient. You'll get lots of blessings. That patient, you'll probably avoid putting that patient through a corneal transplant. And for those of you in developing countries, you don't have access to corneal tissue as easily, or rings or femtosecond lasers, but collagen cross-linking is well within reach, and I would do it. I would do it without hesitation. What is your experience or opinion on ortho-K lenses in regards to energy and time? No experience. Maybe you can tell us. I have no idea. We don't come across too many patients who've had ortho-K in this country, and I don't think ortho-K has been used for keratoconus. So I have no experience in that, and it's not something that we would advocate without good data. One of the problems with keratoconus is you have a thin epithelium. With the other issue with ortho-K is it makes the epithelium even thinner, so you might even put them at risk of infection. What is your preferred technique for cross-linking in regard to energy and time? We're typically using 9 milliwatts for 9 minutes in the majority of cases. How to manage if the corneal thickness suddenly decreases after cross-linking? You don't manage. Yeah, we expect that. It always does decrease, and then it increases with time. And there's nothing to be too alarmed about. We measured all these things in the early days, and yes, we were quite bothered by it, but not anymore. It does thicken up in time. At what point in the disease? I think I'll answer that one. What is your opinion about transepithelial corneal cross-linking? I don't have any experience with it. We do need agents that can enable riboflavin to penetrate. I know there's one's coming out from the Imagine group from Switzerland. I'm looking forward to seeing that. And we do know that we can break tight junctions from using drops. We can also break tight junctions from just lasering the surface of the cornea, keeping the epithelium intact even. So those are options you can consider. And then there's transepithelial, the corneal disruption technique that we developed. You could try that. The contact lens comes out within 48 hours and they heal very, very quickly, but we reserve that for children. Do you recommend cross-linking for keratoconus with best corrected visual acuity of 20/20 in an adolescent? Yes, I don't see any reason why not. If I've got an established diagnosis of keratoconus, I will cross-link an adolescent. Because otherwise, what are you going to wait for? You're going to wait for them to become 2030, 2040, and then do them? Make them worse? No, you want to treat them as quickly as possible. What is the ideal moment to start with rigid contact lenses? Well, basically, as I said earlier on, when they can't wear glasses anymore, then you've got to go to contact lenses. If they can't tolerate contact lenses, then you can consider corneal rings. When could you consider cross-linking? Right away. If they have keratoconus at an early age, they're going to progress. Treat them. Is there any age criteria for corneal cross-linking? So for me, in my books, up to the age of 21, I think that's general consensus, we would treat patients automatically. The moment we walk through the door with keratoconus, we treat them. Above that, you could do the observation bit. But if you have a history of change, so it's good to get the history from the optometrist, has the refraction been changing? And if it's changed in the last year, you can make the assumption that it's continued to get worse, go ahead and cross-link. How is the, don't think I treat that? So that's the age criteria. How is the abbreviation, sorry, abbreviation? I'm not sure what this question is, abbreviation. I'm sorry, I don't know what the question is. Maybe you could type it again, because it might be a spelling error. Does the intracorneal ring affect keratoconus progression? No, it does not. We have had, before we had cross-linking, we were using rings, and those patients, some of them did progress to further thinning in the center of their cornea, and they required corneal transplants. So I don't believe it stops it, but cross-linking does. So if you cross-link and then put rings in, you probably arrest keratoconus. So what is it that's arrested keratoconus? Probably the cross-linking more than the rings. I keep getting asked this question about diagnostics, and you know, I work for a lot of the industry. I don't have any favored devices. All these devices that measure in 3 dimensions are useful. It was scanning slits from ORB Scan, not as accurate for the posterior cornea. Scheinfeld came along, very accurate for anterior and posterior cornea. And now we have OCT, which is even more accurate. However, they all do the job. So I'm not going to get into a discussion about which is better. This is not a competition. Until what age is it recommended to do these types of surgical procedures for keratoconus? Well, as I've said, up to the age of 21, I've said this many times now, I will treat everybody. After that, I might watch them if I believe that they've stopped for whatever reason, and they've stopped rubbing their eyes. Anatomical changes. God, how many questions do I have left? 37. Anatomical changes associated with keratoconus result in less accurate IOL power calculations. What considered should be? This is a whole topic on its own. There are no formulas for lens calculations keratoconus. It is an art form figuring out what lens calculations are. That's not what this topic is about. If you don't mind, Fanny, we can leave that for another time on what I do and what others do in terms of measuring lens power in patients with keratoconus. After some time, removal ring or not any I don't know if there's a question. We do not remove the rings unless there's an indication. So if somebody has to have cataract, we'll keep the ring in and we measure the keratometry based on the keratometry. I don't see any reason. If there's a if the rings are not doing their job or they've extruded or causing a problem, then we take them out. I hope that answers that question. How can they determine size of keranatural? Again, I gave you a very simplistic overview of keranatural. That requires a whole kind of mini course in itself. And there's a art form in how we treat these patients. So I think we need to leave that for another time, and maybe that can be a whole discussion in itself. How does keranatural work exactly? As I said in my talk, it fills in space and changes the anterior shape of the cornea. So it fills in areas where the cornea is depressed. Outside the visual axis, we lift the cornea up and push the cone into the center, and it flattens it. How have you heard about intracameral riboflavin for keratoconus? Intracameral? No, I haven't, and I don't know if that's such a great idea. We were trying to do. I've heard about intra corneal, where they make a flap. I think it was Canalopoulos who came up with this idea. I didn't think it was a great idea because you're weakening the cornea by splitting the cornea. But he would use a femtosecond laser, create a flap, inject riboflavin. It would absorb very quickly, and then you go ahead and do cross-linking. Many ways to skin a cat, but not intracameral. I've not heard of it, and I have never done it. Is there any risk of keratoconus recurrence after PKP? Well, everybody talks about inferior steepening after a penetrating keratoplasty. Please, please don't do a penetrating keratoplasty in these patients. If you come across a patient that's had a penetrating keratoplasty and they've got inferior steepening, in all probability, it's the residual cone, that's the residual cornea that's steepening. If that's the case, you might want to cross-link the periphery. And that's what I do in all these patients. And sometimes if the astigmatism is really bad, then I do a sort of tuck-in wedge resection. Topic for another day. This is really advanced cornea that we're talking about. Cornea layers 5 or 6. What does it matter? You can count as many as you like. The Sophia Bravo, even though DLK is much better than keratoconus, vision rehabilitation, there'll be cases where you cannot do DLK. Yes, that's right. What are your indications for doing a PKP rather than DLK? Well, if I've got a big scar that goes from front to back involving Descemet's membrane right in the center, then I might do a penetrating keratoplasty. But how many penetrating keratoplasties have I done in patients with keratoconus? And I get extreme cases. I can't think of any actually for the last, before I left the health service, probably 18 years, 17 years. I did one patient who's one-eyed, and what I did was actually he had a lot of keratoconus, and I sutured his graft in asymmetrically, so I pushed the scar and a lamellar graft out of the way, and that worked quite well. So there are jazzy things we can do, but if there's a scar back in the center, then it makes sense to do a penetrating keratoplasty. In your experience, what is the percentage that decreases in rejection grafts? Right, compared to penetrating? There is no significant rejection in anterior lamellar keratoplasty. If there's any kind of rejection, subepithelial rejection or epithelial rejection in the first year, treat lots of steroids. I've seen 2 cases, and I do a lot of these, 2 cases of stromal rejection. That can be quite tough. The cornea can get quite edematous. Treat them with a lot of steroids, IV and otherwise, and then eventually clears up again. The vision is never as good, but it clears up. You don't see rejection like penetrating keratoplasty. And how long will lamellar grafts last? For the patient's lifetime, whereas the PK will eventually poop out in about 70 to 20 years. 20 years is the mean. Steroid regime post crosslinking, I don't use any. I only use antibiotics for a week, and that's it. Why not? Because I want, it's an inflammatory reaction. I want that collagen crosslinking, and there's no studies either way, so I don't use steroids unless they're really very photophobic afterwards. What biomechanical factors are currently believed to play a significant role in the progression of keratoconus? Well, right eye rubbing is the biggest biomechanical factor. I can't think of any others. Sleeping maybe on the eye is not a good idea. So if they are sleeping on their face, you might want to put them in shields. In the realm of cutting-edge ocular therapies, could you highlight any emerging approaches that aim to holistically address the multifaceted challenges posed by advanced keratoconus? Wow, that's a question. Emerging approaches that aim to holistically address the multifaceted challenges posed by... advanced keratoconus is advanced keratoconus, and I can't think of holistic approaches besides doing a lamellar transplant in somebody with very advanced keratoconus. I've given you the gamut of what we do in the allopathic side. Holistically, I'm not an expert. There's all this energy testing and crystals and all sorts of stuff. That's beyond me. That's more Californian. So if you don't mind, I'm going to go on to the next question. Can you explain more why keratoconus is not inflammatory? I said it is inflammatory. So, one line, keratoconus is a result of inflammation. Have you got it? The textbooks say otherwise. The textbooks are wrong. They all copy each other. Keratoconus is an inflammatory condition. And I think there was a recent paper written by somebody that actually states the fact. So please read that article. How practical fruitful is it to have intracorneal ring segments after keratoconus crosslinking? What about region? Look, I think that I've already discussed these things. We put rings in, they work. Comparative things for a little bit of difference here and there, I really can't get into that. There have been people who've done those studies, crossing first, crossing afterwards, and so on. The goal is to reshape the cornea and to get patients to restore their vision. So consider that when doing whatever procedures you want to choose to do. Again, there's no competition here. Our goal is to look after patients and get them to see as well as possible. Can max be used as an indicator for severity of progression? It is used as an indicator, but you need to look at everything. You need to look at the other factors too. And what's really useful is subtraction mapping. If you can see posterior elevation, that's increased, an increase in posterior elevation, that is really probably more of a hallmark than all the other parameters. But it's good to look at all the parameters for keratoconus. Kmax, people, it is interesting how we as doctors sometimes can get a little bit lazy and just look at one parameter and use that. You're doctors, you're thinking individuals, you've got a brain, you've got a subconscious mind that processes information for you. Look at all the data and come up with a collective analysis as opposed to one thing. Does it mean if patients is greater than 21 years, you should establish progression before CXL? Yeah, that would be ideal. And usually, I haven't come across too many that come to see me, because usually they've been told by the opticians they're progressing. If I've got no information, then I might watch them. What would be the cutoff pachymetry value? Well, you can use 400, but if you've got slightly thinner corneas, you can use hypotonic riboflavin to thicken up the cornea. Can we repeat crosslinking? If yes, after how many months? Well, why would you repeat crosslinking? If it worked, you would only know if it's not worked after maybe a year or two. So that I have repeated crosslinking 5 to 7 years in some patients, and more often than not, they started rubbing their eyes again, and they will tell you that they can't help themselves. And I tell them that we'll crosslink them again, but there's no guarantee the crosslinking is going to work if they don't stop rubbing their eyes. So it's you can crosslink them again, but you don't, not after months, after years. And if you found that it's not worked. So I think you're asking about genetic testing and treatment genetically. Nothing has been done. There's nothing. We haven't got clear genetic tests for keratoconus. Avellino, the company has looked at this, and it keeps looking at it, and they do have some reliable data, but you don't have a single gene. So multiple genes, and that's a big topic. But again, remember I said to you, keratoconus is multifactorial. There are many reasons for it. How do you manage hyperopic keratoconus? I manage hyperopic keratoconus. I haven't seen it too often. I've seen mixed astigmatism. I would treat them the same way as I treat any keratoconus, cross-linking first, and then so on. How are toric lenses going to help as the astigmatism is irregular? Well, that's something that I don't mean. Toric lenses will help if they're grasp pins. I think you mean contact lenses. I hope you mean contact lenses. If somebody has good spectacle vision with a toric spectacle correction, the chances are they will get an improvement if they have a toric ICL. So if you're talking about ICL. So I hope that answers that question. But it depends on spectacle correction. If it's contact lenses, of course, toric lenses are going to help in keratoconus because you're creating a whole new anterior surface. I can do cross-linking for less than 400 microns. Yes, of course you can. Congratulations. Just make sure that the cornea is thick enough when you use ultraviolet light. Well, people are questioning whether that's necessary or not. I think the jury is still out. You can go ahead. The worry was that we would damage the endothelial layer. What I do in corneas that, as I've already mentioned, that are thinner than 400 is I use hypotonic riboflavin, and I check the corneal thickness before I go ahead and ablate. Some people put a contact lens on and then exposed to ultraviolet light. Other people use a bit of cornea. There are many ways to do it. Please tell us about the ideal contact lens. I think there's a lot of contact lens questions. I'm not a contact lens specialist. I think it may be a good idea for CyberSight to have a contact lens practitioner talk about contact lens fittings in keratoconus. So we'll try and recruit somebody to do that for you. Please let us know about your interest in this area, and we'll arrange that. Does age matter through the treatment process? Yes, the younger they are, the more chances they're going to have of progression. So something to consider. I think we've been through that. That's why we treat younger patients more aggressively. How much progression is considered progressive? Good question. How should we do topography in keratoconus to see the progression? So as I mentioned that already, what we need to do is look at the three-dimensional topography and subtract your previous results, your current results from the previous results to see if there's any progression. especially in the posterior elevation mapping, because if that's ectasia, right? You get thinning of the anterior and posterior, or the protrusion of the anterior and posterior, and thinning, the combination of the three, and it has to be significant. So there are no numbers. Everybody wants numbers from me. There are no exact specific numbers here. You've got to take a look at every patient. They may have a little bit of protrusion in an eccentric area. You need to know if it's real or not. You can check them again, repeat the tests. Can crosslinking be repeated? I've already answered that question. What method of IUP measurement do you prefer? We use the toner pen, and we look at corneal thickness. We can use a toner pen peripherally where the cornea is thicker, and that usually is helpful. How do you treat if glaucoma develops? Well, we treat glaucoma like we always treat glaucoma. We just have to be sure, a good question about measuring their pressures and making sure that the pressures are real and they're corrected for corneal thickness. I'm not going to get into epi-on or epi-off. We've already discussed that. Can you please explain more why keratoconus is not inflammatory? I got this question again. Keratoconus is inflammatory. Okay, it is inflammatory. Oral use of riboflavin can be useful for treatment. No evidence to suggest that it does. You've got to have a certain level of, you need the combination of riboflavin in the cornea and ultraviolet light of a certain level and exposure, a certain frequency and a certain level of affluence for crosslinking to take place. So riboflavin orally is not really going to do it. What about crosslinking in a thin cornea? I'm not sure what the question is, so I can't answer it. I'm sorry. As regards the question of orthocane current, is it not at all recommended? I don't have any expertise in the area, and I think that it would be unwise because they have a thin epithelium in that area, and you're going to be putting a contact lens on, forcefully pushing that area down. You could erode a thin, if they only have one cell layer, and you erode that, you put them at risk of a contact lens with an epithelial defect, they could get an infection. Which is better to use in cross-linking, isotonic or hypertonic riboflavin? It really depends on how thick the cornea is. Isotonic is what we use most of the time, but we do check the cornea before we go ahead and expose the cornea to ultraviolet light to make sure it's of sufficient thickness before we proceed. I hope that answers that question. We'll use hypotonic if the cornea is thin. So what I do is I take off the epithelium, measure the cornea, and we decide whether I'm going to use hypotonic if the cornea is less than 400, or isotonic if it's at about 400. What's preferable? And the last question here, what's preferable? Cross-linking and intracorneal ring at the same time or different sessions? As I said before, sometimes when we do cross-linking, patients improve on their own. Their vision gets better. The best corrected vision improves, even though the topography doesn't improve. Maybe it's because the refractive index of the cornea changes. It's possible. So they may not need rings. So I'd rather do cross-linking first. And if they need a ring, then I go ahead and do the ring. I hope that answers that question for you. Well, that was a marathon. There must have been about 70 questions there. If there are no further questions, I think I answered them all. I'm going to call it a day, 20 minutes over time. Well, I thank you all for your attention. I think we certainly generated a flurry of interest there. It would be great to get some feedback. I know that this particular seminar will be posted on the CyberSight website, and it's a reference point for you to come back and go to. I hope. I'm sorry, I've been a bit dismissive of some of the questions. I didn't quite understand some of them, and some of them were repetitive. So apologies to those who feel they've not answered their questions. I hope you found this session useful. I'll try and do some other sessions on cornea for you and other things. It'd be great to get some suggestions from you as to what you'd like us to talk about.